I'm a board certified urologist by training, finished my residency in '83 and practiced nearly all aspects of general urology from 1983 until the year 2000. And then in the year 2000, I guess through the late 90s, I had tried to taper some aspects of general urology because I found preventing unintended pregnancies through vasectomy to be so rewarding. And I got the impression that there wasn't anyone else out there who was trying to make vasectomy as available, affordable, and acceptable as I thought it should be. So I started to focus on that and started to do vasectomies outside my own office. In 1990, the no scalpel vasectomy was kind of introduced in North America, having been sort of the standard of care in China for years. And that made vasectomy very portable. So in the last half of the 90s, I started to do vasectomies at a number of locations outside my office, both in Planned Parenthood facilities and county health departments. And that required that I be away from my office, which was right next to the hospital. And I found myself asking my colleagues to cover for me because you're not supposed to be more than 30 minutes from the hospital if you have a patient in the hospital, especially a post-op patient. So I found that increasingly difficult, even if it was weekends. And that is what ultimately led to my need to stop accepting new general urology patients, both in the hospital and in the office setting. And that was a step that I made in 2000. I didn't stop seeing new general urology patients. I would continue to see people who were seeing me for ongoing conditions. And I would even do some urology operations for a few years after 2000. But I felt that it was a disservice to my patients to do something that I wasn't practicing all the time. And so gradually I would start to refer, if I was following someone for difficulty urinating and suddenly they passed blood and turned out that they had a big kidney tumor or something, after a while I would refer them out. And gradually there was an attrition of my urology patients as the number of vasectomy patients built up. And that actually allowed me also to go to a variety of, an increasing number of different locations throughout Florida, until eventually I was going to 21 locations outside my office. Sperm are made in the testes, and they combine with the other components of semen, which are made by the seminal vesicles behind and beneath the bladder and the prostate beneath the bladder. Sperm only make up about 2 to 5% of the actual seminal volume. And they are transported up from the testes to the rest of the reproductive organs, the prostate and seminal vesicles, by tubes the size of spaghetti. So they travel up through the inguinal or groin areas, down into the pelvis and around the back and underside of the bladder. So they are about 13 inches long. And they're just underneath the skin, and the scrotum is such thin skin that it's fairly easy to feel them in most cases, and to just lift them through a tiny opening in the skin to interrupt the flow of sperm from the testes to the rest of the reproductive tract, following which the body sets up a recycling process to recycle the sperm that can't get out the traditional way. So vasectomy is nothing more than a prevention of sperm made in the testes from reaching the semen by doing something to the vas tube, either clipping it or dividing it plus taking out a little section, or cauterizing it, or dividing it and throwing the ends out of alignment. There are different ways of accomplishing that obstruction. The word vasectomy is kind of unfortunate because it implies ectomy, meaning removal of. So if you have removal of your stomach, it's a gastrectomy, or removal of the colon, it's a colectomy. And so that can be scary to people, to think that part of their body part is going to be removed. But traditionally, the first vasectomies, which should never have been called vasectomies, they should have been called maybe partial vasectomies at the most, involved removing a little segment of the vas. And that's how ectomy came about. Whereas in females, sometimes it's referred to as a tubectomy, but more commonly referred to as a tubal ligation, a tying off of the tubes. And I guess that initial shows you the power of words, that the word may have scared people off initially, and perhaps sometimes even still today. There are 3 steps in any operation: how you make it so it doesn't hurt, how you get to your target, and what you do to your target when you get there. So one step at a time, how you make it so it doesn't hurt. You could put a fellow to sleep to do a vasectomy, and some doctors still do. I think it's a little overkill to do that. Don't think I've ever put a patient to sleep specifically for a vasectomy. But I guess if your office is right next door to a surgery center which you own, and you're trying to keep your surgery center busy, and you get a particularly squeamish patient, or if it's not in your personality to know how to relax patients on a one-on-one level, and he has insurance that'll pay for the anesthesia to put him to sleep in your surgery center, that might happen. I would guess that probably, I'm just throwing it out there, maybe 5% of vasectomies done nowadays are done under general anesthesia. The other type of way to make it so it doesn't hurt would be local anesthesia, where a little bit of local anesthetic is injected into the skin and around each vas. That can be done with a needle, or it can be done with a spray applicator, which is a kind of a pressure spray applicator applied to the skin, and then a very fine stream of anesthetic penetrates the skin and around the vas and does a beautiful job numbing up. And that doesn't feel like a needle at all. It feels a little bit like a finger flick or a rubber band snap. So once you have the vas anesthetized and the skin anesthetized, the next step is to get to your target. And prior to 1990, I would lift the vas into position beneath the skin on the sidewall of the scrotum, anesthetize the skin, and then make an incision with a knife or a blade. It wasn't a very big incision, maybe 1/4 of an inch or so, and then the vas could be lifted through that, but it was an incisional or traditional vasectomy. Starting in 1990 with the no scalpel vasectomy, it became more expeditious to lift each vas in turn right into the midline on the front wall of the scrotum, and then use a little instrument that looks a little bit like a pointy hemostat. I even have one here if you give me a second. And this instrument is just if you can see here, just a very, very pointy device. I'll put it against my shirt. It's nothing more than a curved instrument, but it's fairly pointy. And you can pass this, if I poke this into my skin and then put the 2 tips together, I could then put both tips in and then gently spread. And that would make for a little opening in the skin. And then what I would do even before doing that is try to lift the vas into position beneath the skin, and then retrieve it with a little grasper, which we call a ring clamp. So once the vas is in the ring clamp, then you can use this to make a little opening in the skin, and then this vas will lift right through. So that is the 2 forms of access, traditional and no scalpel. And then the third step in the operation is what you do to the vas when you get there, and when you lift up that little loop of vas. So if you're lifting, let's say, a little loop of vas, I'll put it against my shirt so it's easily, that's really not even that big. It might look a little bit like this when you lift it through the skin. Now what you can do is you could tie off both sides and then remove a little, maybe a 1/2 inch section between them, or you could cauterize the inside with a little thermal or electrocautery unit to destroy the inner lining so that it'll seal over solid. Or you could divide it with or without cauterizing it, and then sort of throw the ends out of alignment. If I sort of imagine this being a divided vase, now if I throw the ends out of alignment, there's a sheath around the vase that's a little bit like a sheath around a wire. And if you can imagine yourself opening that sheath, reaching in, snipping that copper lead, and then bending one end outside, and then putting a little clip on the empty portion of the insulation between the inside one end and the outside other end. You can follow that. Now the two ends are like this, and they're separated by a tissue layer. You put your clip in between them. So now this end is outside the sheath, which travels like this, and this end is stuck inside the sheath. So that's a beautiful way, and probably the most dependable way of preventing those ends from coming back together and recanalizing. So for a vasectomy, you want to avoid complications first and foremost. And one complication could be that if you didn't correct any bleeding blood vessels, then the person could develop a blood clot in the scrotum. Or if you didn't do your prep right and make sure that everything was super sterile, you could get an infection. Both of those are exceedingly rare. The other could be that the ends could grow back together again. In other words, if I just had a little bit of an end separation, the body could form kind of a granuloma around this, and then little micro channels form between the two ends. That would be failure, which is also considered a complication of vasectomy. People, and rightly so, consider vasectomy the ultimate dependable form of contraception. And we have to live up to that reputation. So we think that a failure rate of 1 in 500 vasectomies is unacceptably high, when that is even 1 in 500 is far less than the failure rate of most other forms of contraception. On the day of the vasectomy, it's advised that men go home and do nothing but lie around at home. The next day, they can do all the walking and driving they want, but they probably shouldn't do any yard work or sports or heavy lifting. So if that's still considered recovery, then that would be 2 days. And then the third day is you can do whatever you want. Now, if recovery is defined as limitation of activity, then it's 2 days. If recovery is defined as the complete disappearance of any symptoms that, boy, I can't even feel anything, even if I concentrate on it, then the recovery could be 2 or 3 weeks. Because, if you're focusing on something, like if I asked you today, if you, without even looking at your image on the screen, or, well, if I asked you right now, are you wearing a watch, without looking at your wrist, your mind would be able to focus on your wrist to tell you whether you're wearing your watch or not. So yes, you can sometimes focus on, yep, I had something done down there. But if you're preoccupied watching a show on TV or preparing dinner, you might forget all about the fact that you had a vasectomy. So I'm not really sure what recovery means. Certainly in terms of activity, it's 2 days. In terms of noticing that you had something done, or even maybe a little bit of a lingering discomfort when you get up out of a sitting position, it could be a week, sometimes 2 weeks, but eventually symptoms go away. That would vary a little bit from culture to culture, and maybe saying the same thing country to country. The questions might be the same that you just asked. How long does it take? What's the recovery? Probably once they already know that, they're concerned, number one, is this going to hurt? And number two, is this going to change my sex life? And by sex life, I mean libido, ability to attain and maintain an erection, sensation, and sensation of orgasm. Those would be the 3 big issues there. Those might be the issues in a society. Well, those are the issues probably in all societies. In some societies, there are concerns that vasectomy could interfere with your ability to do heavy work. When I think of that, I think of India, that men are afraid mostly that they won't be able to do heavy lifting, that their skeletal muscle strength will deteriorate somehow, which is no basis in fact. Let's see, what else would Americans worry about? It's mostly, it's mostly discomfort and their sexual function. Maybe can this be reversed? That might be a question, but surprisingly few men who are getting vasectomy are thinking about vasectomy reversal. With regard to, does it hurt? I might say that, have you ever had a blood sample drawn? Yeah. I said, well, did they put you to sleep for it? No. It was just a little something for a moment. Yeah, that's what it's like. Maybe I would say that the discomfort during the procedure is during the administration of the anesthetic, and it's very fleeting. It's just a snap. In this case, it feels more like a rubber band snap than a needle stick. After the vasectomy, is it going to hurt? Yeah, it may give you kind of a, to use the vernacular, a little bit of a kick in the nuts sensation the day of and maybe the day after, where you're feeling some discomfort locally and maybe radiating up into the abdomen. But we have, in the process of calling patients and follow-up, actually done, at one point, we're asking men if they had taken the Tylenol samples that we had provided. About 50% had, and about 50% hadn't even taken Tylenol after their vasectomies. So that maybe answers the question in a quantitative way. How much pain am I going to have afterwards? There's going to be a 50-50 chance that you're going to require a couple doses of Tylenol afterwards. And I have to call in a prescription pain medication in maybe 1 out of 500 to 1 out of 1,000 vasectomies. And those are guys who often anticipate having a lot of post-vasectomy pain. That was the one question. Sex life. With regard to sex life, we actually did a poll because we wanted to know what our patients were thinking. And on our website, we have the results of this poll. We sent out 400 questionnaires and asked them the 3 or 4 questions that I had posed before: libido, quality of erectile response, sensation of orgasm primarily. And they could answer no change, slightly worse, much worse, or slightly better, much better, with regard to like libido or sensation of orgasm. And it was the middle of the road for most of them. 85 to 90% said that there was no change in any of those parameters. A few of them said that things were a little bit worse. I should be going the opposite direction because you're watching me on a video screen. So if left is bad and right is good, then a few of them said that things were a little or worse. And a few said they were much better, but the betters outnumbered the worses. You see what I'm saying? So some men actually felt that their libido was greater. Maybe it's because they didn't have to cover up or pull out anymore. Some of them said that their sensation of orgasm was better. Again, maybe the same reason. So we tell people that we never tell guys absolutely for sure that there's going to be no change in their sexual responses. But if it does change, chances are a little bit better that it'll be for the better rather than for the worse, based on our own questionnaire, which we repeated. So we sent out 400 questionnaires, got 119 responses the first time, and about 110 responses the second time. And by and large, almost everybody was, we said, are you happy that you had your vasectomy? And even if they said that their responses weren't quite as strong, they were happy that they had had their vasectomies. Well, the question always comes up, given concerns about the environment and climate change, are you seeing an increase in the number of child-free men who are opting for a vasectomy? And we have a database and can pull that up. And I think I pulled that up about 6 months ago. And it showed that about 10% of our patients were child-free in 2010 or 2009. And then 10 years later, about 10% of our patients had chosen to have no children. So that was kind of a no change. Probably the age range hasn't changed at all. They've had enough kids. I've had enough, doc. Or I don't want kids. I don't want kids, doc. Just never was interested. don't want to have any, or doc, we have as many kids as we want. We have to pay for them. So even if you have insurance, now there's some groups don't have to pay at all. The veterans don't have to pay. They can get it through the VA, or sometimes the logistics make it a little bit challenging for them. It can be a long wait time, or you're being done, for example, by resident doctors instead of doctors who've had loads and loads of practice. So they well, I'm not sure I want to have it done through the VA. Other VAs are fine. That's it. Those are the only ones who guaranteed not to pay, or unless you go under Title 10, which is a federal program for men who don't have insurance and who are of low income. Title 10 will pay for it, but there are limited ease of accessibility. For example, if you're in my county and you want to partake of the Title 10 program, you need to go to a county health department, which is in one of the furthest recesses of the county, to undergo financial screening. And then they're going to send you for a physical exam to another health place, which could be on the other side of a relatively large county. And then you're going to go for your vasectomy. So they make it logistically challenging. It's doable, but it's challenging. Now, that's my county. There are other counties which try to streamline the process and make it very easy. One quick trip in. They might do a very cursory physical exam, but they'll make sure that you're well coached in vasectomy. They'll refer you to our website if we're the ones doing the vasectomy for that county. They'll say, read over all this, then call Dr. Stein's office, and we'll send your paperwork to his office. Call him in a week or so. He'll have the paperwork, and then you can arrange a date with him. So sometimes it's very streamlined with some counties. But that's a small minority. The rest of the patients are either paying for it because they're not veterans and they don't qualify for Title 10 funds, or they don't want to go through that rigmarole, or they have insurance, but they have an insurance deductible. And while the Affordable Care Act mandates that female forms of contraception are not subject to the deductible, male contraceptives are. Because women are accustomed to being the most in charge of reproductive health, including both having babies and in preventing babies. Well, mostly the things that we've discussed, that the most common misconception is that it's going to interfere with your sex life, or that it's going to hurt more than you expect it to, or that insurance companies don't pay for it. Those would be probably three of the main ones. That is easier than you think. A couple of studies show that there's little change in men, but a couple of studies also show that the partners of men who've had vasectomies actually enjoy their sex lives more. Now, maybe it's because they're off hormonal manipulation. Maybe it's because they don't have to worry about getting pregnant, but they enjoy their sex lives more. And that might be an important thing to take into consideration.